Okay. Good morning, everybody, to the Ceylon College of Physicians Symposium on Emergency Medicine. We will have 3 speakers today. Each session is about, lecture is about 20 to 23 minutes, and we will take questions after each lecture. So the first speaker is Professor Dr. Parash Doshi from Malaysia. And without much ado, we will proceed to listen to Dr. Doshi.
All right, a very good day. I would like to wish the delegates who are viewing this presentation for the annual Congress organized by the Ceylon College of Physicians. I would, at this juncture, like to thank the college for the fantastic effort at putting this annual Congress together in light of COVID. My name is Paras and I'm from Malaysia, and I'm actually practicing as an acute advanced internal medicine consultant. I was actually one of the pioneers when it came to advanced acute internal medicine in Malaysia. And I'm pretty excited to be sharing my experiences with all of you here. In my country, well, I do hold a number of posts as well, both within the ministry as well as in the academy. Besides being the vice president for the College of Physicians Malaysia, I am also the president for MIMUS. And MIMUS is our Malaysian Advanced Acute Internal Medicine and Ultrasound Society. And I also am the lead for the Parallel Pathway Training Program for postgraduate in internal medicine. Well, you can say I'm lucky because some of us, we are probably practicing and doing something which we may not enjoy, but I have the good opportunity to be enjoying what I do because these are 2 fields that are particularly interesting to me, and I'm passionate about both acute medicine, postgraduate training, and particularly how ultrasound can actually revolutionize the way we physicians practice internal medicine. So the topic for today is, of course, how advanced acute internal medicine has fit into Malaysia and our experiences with the medical admission unit. So acute internal medicine, advanced acute internal medicine deals with the best 72 hours of a patient's admission, all right? And in my opinion, this would be the first 72 hours. Studies have conclusively proven that the first 72 hours are critical to a patient's mortality, and doing it right within the 72 hours makes a big difference to their care. And of course, yes, this is something that I truly believe in and focus on in managing a patient. So what is advanced acute internal medicine? It's basically the hospital specialty concerned with the assessment, diagnosis, and treatment of adult patients with urgent medical needs. It was formally recognized as a specialty in 2009, previously under general medicine. And in recent times, it has become even more important because you've got all the subspecialties with very, very detailed niches, and AAIM will form the bedrock of that internal medicine subspecialty. So the next question is, what do we do? So there's a broad spectrum of clinical work within the specialty, including the immediate management of life-threatening medical emergencies. We focus on the initial 72 hours, and of course, we look at the provision of ambulatory care. So what else do we do? We focus on acute medical emergencies, as mentioned, but also on the development of pathways. So for patients who may not require immediate admission, for example, those who come in with chest pain, who may not require immediate admission, for TIAs, or for heart failure patients, or for uncontrolled hypertension, yes, we develop pathways for that. What do we learn? So basically, we, as part of the AIM program, we look at the development of specialist skills as a core part of the training. We develop practical skills like echo, ultrasonography, bronchoscopy. Some of us may go on and gain qualifications in management, leadership, or education. We might be focused on MRCP teaching or the Medical Masters MEd program. Yes. So where are we based and what are we doing? So we are hybrids with roles that are common to both. We are similar to what acute medicine physicians will be doing in the UK. And we also have a role similar to what the hospitalists are doing in the US. In addition to performing a role that encompasses these two, we also see outpatients, all right, the new patients in the outpatient clinic, and we also follow up inpatients who have been discharged rapidly from the ward. So how can we make a difference? So we basically are utility physicians, pretty similar to the utility soccer players that you see who can play defense, midfield, depending on the local situation, we can adapt. So we are well suited to our local healthcare needs because like in Asia, many hospitals do not have the full-fledged sub-services like gastro and nephro. So sending one of us of super physicians or utility physicians, we can go up and set up thrombolysis services, even though there may be no neurologist, or we can perform gastroenteroscopy, even though there may be no gastro services. So where do we work? Basically, we can be positioned in AMU, MAU, MAPU, AMAU, HW, all those acronyms, or even a general ward. We work best within an acute medical unit, right? Or something similar to that, whatever you may decide to call it. We also work well within the high dependency wards like the CCU, HDU, or the HDW. And we also function well in the general medical wards, where we have contributed substantially to reducing the length of stay. So what's the big deal with ultrasound? So ultrasound is basically our stethoscope, all right? We love it because it has been proven to be superior to chest x-ray, instant diagnosis and management. And of course, all of us have been confused. Is it a consolidation? Is it an infusion? And ultrasound guided tapping for fluorocentesis has definitely reduced dramatically the chances of liver perforation. Does it make a difference in the ward, you may ask? Definitely. When you want to pick up the differences between AKI and CKD, you want to look for calculi, we can pick up obstructive nephropathy because we see the kidneys right enlarged. Liver abscesses, fever, scan, oops, we pick up an abscess. We can even scan for DVT without waiting for radiologists. So we don't have to worry about DVT being a clinical diagnosis, but sometimes it's in the gray area. Hemoglobin is low, you're worried about anticoagulation, so we can scan for DVT. Does it make a difference in the ward? Yes, it does. Looking at acute versus chronic heart failure, we can visualize hypokinetic regions corresponding to ischemia. Don't need to wait for cardiac enzymes. BP drops in this sort of patients. We can pick up whether there's an acute MR, is a cardiac tamponade. We can even look at volume status when you want to resuscitate these patients. What else can we do? A diagnostic OGDS, right? We can perform those in the ward. Proctoscopy, colonoscopy for the adventurous ones. We can even do a bronchoscopy. Amazing, right? When you have a patient who's ventilated, mucus plugging, or you want to do a BAL in a patient with fever, not really sure about TB. All this basically reduces the length of stay and helps us utilize our limited resources well. So where else can we be stationed? We can be at the emergency department where we have a mobile AAIM team. We actually go and review the cases in the emergency department. And we have found that we are able to reduce the bed waiting time. We are able to discharge from the emergency itself, which is fantastic. We can also redirect and change the diagnosis for certain cases, send them to the correct wards. All this is a boon to patients. Where else can we be stationed? We can be stationed at a rapid review clinic. So this is used to look at patients who would require admission, who were actually thought to require admission, but they don't. So we actually see them the same day in the clinic or the next day at the clinic, and basically we save the admissions. So we can also review patients who were discharged early from the wards, all right? And all this helps reduce our length of stay. So let's look at the numbers and the real life experience thus far, because in theory it's always good, but numbers is always very important. So looking at the emergency department attendance for patients, you can see that we have to deal with approximately 20,000 patients on average a year. Crazy amount, all right? There's almost a population of some of the smaller countries like Brunei. So 20,000 admissions attending, and out of that 17,000, 15,000, right? Those are the patients from the green zone. You can't do much about the red and the yellow because they are unwell, but the green is definitely something that we could look into. So when we looked at the total number of cases, you can see on average, you're talking about 36,000 cases that actually come into the medical wards. That's about 100 to 120 patients a day. And when your ward capacity is only 400 beds, you're talking about filling up your entire medical department in 3 days. Huge pressure on beds. So we looked at the admissions. Most of them, as expected, were coming from the green, yellow, and of course, fewer from the red. So the green and yellow is what we decided to focus on. And we wondered, what are the cases that we're seeing? ACS, heart failure, UTIs, CAPs. These are cases that definitely can be, do not necessarily need to be admitted. They are the walking wounded. They can be seen as outpatient, provided that you have a confident consultant-led service that is able to make decisions quickly. So this was our hospital Malacca model. So Malacca is actually a small, medium town in the southern part of Malaysia, and we had an AIM physician position there. And this AIM physician, you can see from 2015 to 2019, you can see that there was a substantial increase in the number of admissions that were reviewed, from none in 2015 to 77% in 2019. Fantastic jump. In terms of reduction in ED admissions, you're looking at 18.5%. That's almost 1 in 5. Almost 1 in 5. So that's fantastic. Out of 100 cases, you can block out approximately 20 admissions. That's great. Who don't require an admission. Fantastic. The reason why this worked, as opposed to conventional services where we do have medical reviewing in the ED, this service was consultant-led. So we had the general actually swashbuckling in the ED, reviewing cases and making quick decisions, quick, confident decisions, because it was led by the consultant itself. And 20 patients per day, if you translate this to a general ward, it makes a big difference in terms of the bed occupancy rate. So the number of cases that were reviewed in the non-medical wards, yeah. So the team was also reviewing cases in the other wards as well to decide whether they really need to be transferred over to medical. So from a measly 20% in 2015, it's a huge jump to 100% in terms of the cases that were being reviewed by the specialist. So again, it is important for the consultant to be directly involved in the management of these patients. The length of stay in the high dependency ward remained somewhat similar. There was a good drop in the nosocomial infection rate when you have an AIM consultant on board. So mind you, this can happen even though you may not have an infectious disease specialist. You may not have an ID service in the hospital. But because our AIM physicians are also trained in ID, they can bring their know-how and look into dropping nosocomial infection rates. We were confident in withdrawing therapy at the ED, all right? So that saved a lot of patients from being admitted into the wards. The high dependency ward mortality rate also dropped with the advent of acute medicine in the HCW. And I think pretty impressive is the OGDS rates, all right? 630 OGDSs were done by our AIM physicians. Really good when you are having a patient who can't go home because an OGDS has not been done. So this leads to quick decision-making, earlier discharges. Particularly impressive is the average bed waiting time. So before we had our acute medicine and the MAU, you can see that the bed waiting time was almost 280 minutes on. Now this is an average value in November 2018. That's almost 5 hours. And this is 5 hours of waiting for a bed after you've decided that you need a medical bed. And with 5 hours, I believe if you were in Colombo, you'd have taken a flight. In 4 hours, you'd be in Dubai, Delhi in 3 hours. With 5 hours, you're almost reaching Beijing, 3/4. So putting that into perspective tells you how much time is wasted when a patient is waiting for a bed in the ED. And sometimes they may not require a bed. They may not even require the admission. So having the MAU team, you can see brought down the bed waiting time dramatically in 2019. So same November, all right, which is when we do see a lot of cases, you can see that the bed waiting time has dropped from 280 to almost 50 minutes, all right? That's a huge drop in terms of the bed waiting time, and it made a telling difference in bed waiting time for the emergency department. So a really good achievement when you have an AIM consultant who is positioned in between the ED and the general medical wards. So you are actually a very good gatekeeper, and you're actually able to screen and decide who really needs to be admitted. So imaging at the bedside, we love this because it's ultrasound. You can look at it, it's a pocket, fits in your pocket, connects to your phone. So in short, pocket ultrasound has become, in my words, physician's stethoscope 2.0, all right? You don't need a stethoscope anymore. We need an ultrasound machine. And the way costs are being driven down, in the foreseeable future, this will be our stethoscope. So chest x-rays have served us till now, all right? We already have chest x-rays, but is that enough? All right. So I'm sure all of us have been in this situation. All right. It's a gray area. We need to decide how to move. So are there basically any situations that would necessitate a lung ultrasound? So the commonest reason looking at this picture is we see the haziness, right? What do we see? Haziness. But our confidence is limited, isn't it? What do you think might be going on? Is it consolidation? Are we dealing with, is the lungs appear to be hyperinflated? Is there or is there not heart failure? Sometimes you want to do an invasive procedure, but is it ideal? I mean, imagine sometimes you even, this is an AP or a PA film, all right? So it's a diagnostic dilemma. If you want to do an invasive procedure, is it safe? Is it consolidation? Is it effusion? So what would we do now, isn't it? It's a dilemma. And of course, let's not forget about states that may coexist together. For example, you may have sepsis, you may have fluid overload, all right? Which one's predominant? Are they both there? Which one's significant? It's a diagnostic dilemma. If you were to look at this chest x-ray again, all right, states that coexist together. Is there acute pulmonary edema? Are the vessels prominent? Is there COPD? All right. So is definitely a problem with ultrasound. So let's look at the evidence, all right? So the evidence looking at the ROC curve, all right? All of us love that, all right? So let's not forget. So the lines in green are what we want, all right? Red, good, but blue is definitely worthless, all right, to us. So let's look at the EBM, evidence-based medicine for consolidation. So you can see here, if you look at chest x-ray versus ultrasound, so they found, Cortellaro et al., they found basically that in the emergency department, ultrasound was more sensitive and more specific. Look at the area under the curve, 97.5%, fantastic. And if you look at critically ill patients, Zero Shafi in 2011, ultrasound was definitely superior, right? So reference 1 is at the critical care setting and, at the emergency setting, and reference 2 is at the critical care setting. And you can see that it has made a great difference, ultrasound compared to chest x-ray for consolidation. So let's look at heart failure. So at heart failure, if you look at the factors for heart failure, right, in terms of the odds ratio, you can see that the odds ratio for heart failure is 7, but the N-terminal pro-BNP doubles that odds ratio from 7 to 14. But ultrasound is, wow, at least 4 times better, right, in comparison. All right, you can see that ultrasound trumps pro-BNP, all right, in terms of the odds ratio for heart failure, all right? If you look at acute pulmonary edema, ultrasound versus pro-BNP, the sensitivity, the specificity, all right, MPPV, NPV, AUC, all of them fantastic, all right, far better than what we usually use, which is chest x-ray and sometimes pro-BNP. Ultrasound makes it better. So basically, the ultrasound has outperformed pro-BNP in every parameter. And also look at the confidence intervals, yeah? They're pretty small when it comes to ultrasound. If you look at acute pulmonary edema, again, ultrasound has definitely outperformed, all right, when it comes to acute pulmonary edema in every parameter. For a pleural effusion, all right, you can see that, again, ultrasound has done better. So this was a prospective cohort. All right, there were 42 ventilated patients, all right, unselected ICU patients, and they used the CT scan as the gold standard. And compared to the CT scan, ultrasound outperformed the chest X-ray all the way. Looking at further data here, we can see in terms of the pneumothorax, again, ultrasound has outperformed the chest X-ray when it came to diagnosis of the pneumothorax. This was a meta-analysis, and this was in the chest journal. Pneumothorax, again, comparison of chest X-ray versus ultrasound. Look at those rock curves. Amazing, all right? And if you look at the odds ratio forest plot, it's a no-brainer that ultrasound definitely is the way forward compared to chest X-ray for pneumothorax. For patients in shock, again, ultrasound does really well because hypovolemic, cardiogenic, obstructive, and distributed. We can actually use ultrasound to look at the tank, all right? And this tank is basically able to be assessed using ultrasound, and we can actually distinguish between the various types of shock using ultrasound. So in short, I'm pretty sure you're convinced with how important ultrasound is. For acute medicine in Malaysia, we've now set up a society to take this forward. Is the Malaysian Advanced Acute Internal Medicine and Ultrasound Society, MIMUS. And of course, we have already started in a big way. We have had online webinars because we believe that ultrasound needs to be taught. But with COVID, we have moved further, and we have now started training them online with webinars. We've got really good support from our man of the moment, our DG, Tan Sri Dr. Noor Hisham, who has been spearheading this effort. So we actually had phase 1 training. We had a webinar with 100 physicians, all right, that went online. We had an examination for them as well. And after passing that, we gave them another phase 2, which was local hands-on, whereby they actually have to be trained by facilitators in their own hospitals. So in short, basically, MIMUS is spearheading the acute medicine effort in Malaysia. We are looking at making this prominent in both Peninsular Malaysia and East Malaysia. And we are currently tying up with sister societies in other countries as well to take forward the cause of acute medicine. This has been a wonderful presentation so far. I would like to thank you for your attention and your time. More than happy to address any questions later via email. I hope that you have benefited from this presentation as much as I have enjoyed presenting it to you. Thank you.
Thank you very much, Professor Parastoshi. I think we have a little time for some questions. The audience is invited to submit their questions through the chat system. And Professor Parastoshi is online to answer any questions.
Right. Can I ask you a question, Professor Parastoshi? Now, in your setup in the emergency medicine department, now we see rapid response teams basically attached to the intensive care units who reach out to see, critically ill patients who are deteriorating. Do you have a system where you gonna go and review the patient that will be discharged to the wards from the A&E department?
So the primary purpose of this team was to basically ensure that within 72 hours, physician input has been given, and that too from a consultant level. So if the patients were unwell or they were in the red zone, definitely the ICU team will be there, and the medical team will be there to co-manage it with them. After which they will then go to the acute medical unit. And from the acute medical unit, yes, the physician teams will be there. And upon discharge, we will follow up our patients rapidly, immediately after discharge. The ICU will definitely be there, but those patients will definitely go off back to the ICU rather than coming to the acute medical unit. We do not mix with them. We have our own acute medical unit, so we can handle the ventilators. We can handle critical care as well. So we can set up a parallel service that is able to ramp up capacity rapidly when, like right now, we have the COVID outbreak and the ICU teams are swamped and they've got limited availability. Suddenly the physicians can come in and we can scale up and we can contribute to battling the COVID effort, similar to what the ICU consultants can offer.
Thank you.
Okay, thank you very much, Professor Parastoshi. That was a wonderful presentation. And I haven't got any more questions at the moment, but perhaps towards the end if we have time. So thank you very much, sir, for your contribution.
The college for inviting me.
Thank you.
Right. So next talk will be done by Dr. Krishant Jayasekara, who is a consultant physician attached to Teaching Hospital Karapati, and he's going to talk to us on nasal high flow therapy in the emergency department. Over to you, Dr. Krishant Jayasekara.
Yeah, person. So now, so I'll be talking on high flow nasal oxygen therapy. I'll be spending a couple of minutes on comparing high flow nasal oxygen with conventional therapies. Then I will go for physiological changes that are important in understanding the high flow involved with high flow nasal oxygen therapy, its clinical indications and its application. Then I would go for some scientific evidence behind its use. And also, finally, I will touch on its use in COVID-19 pneumonias. Now, administration of oxygen is the first line therapy in all hypoxemic patients. And conventionally, it's done through face mask oxygen. And we can deliver 15 liters of oxygen through face mask. So there are a few drawbacks with this conventional face mask oxygen because there is definitely the patient is going to breathe at a flow rate around 30 and there is air entrainment and we can't achieve a targeted FiO2. Next problem is this bubble humidification is not adequate and also the air is cool. So the patient's compliance is definitely going to be poor. If a patient does not respond well to conventional oxygen therapy, our next line would be non-invasive ventilation. So for the last decades, NIV had been in the limelight especially for COPD exacerbation and some cardiogenic pulmonary edemas, but there are inherent problems with NIV as well because the mask tolerance and feeding problems, drug administration, oral drug administration, all had been problems with NIV. So to overcome these problems, people were looking for a different mode of oxygen administration. High flow nasal oxygen delivers humidified, heated oxygen at a high flow rate. Most of the initial studies or initial practice was on neonatal age groups, and the studies were also on neonates. But subsequently, people just thought that this could be used in adults as well. Initially, it was used in ICUs and subsequent later on to the emergency departments and medical units. Now, there had been quite a few randomized control trials, meta-analysis and systematic reviews, which I will go through on the benefits of high flow nasal oxygen. This came to further limelight with this COVID-19 pneumonia because the resources were stretched to its maximum in ICUs and people started using more high flow nasal oxygen in COVID patients. Now, if you look at the equipment itself, it delivers heated, humidified oxygen at high flow rate. It has the first thing is it has a air oxygen blender. Then it has a moisturizer, then it has a heated cannula with a comfortable nasal prongs. Now, this is a pictorial depiction of the system. In brief, this is a portable system, portable machine which you can wheel around the ward, which delivers air, oxygen, blended air and oxygen to the flow generator, where it's being moisturized, and send it to the patient, heated to 37 degrees via comfortable nasal prongs with straps. Now you can just, if you look at this picture, you can see how comfortable this is going to be patients. On your left, you have the interface, the mask of NIV. In the middle, you have a conventional face mask oxygen. And on your right, you have the nasal prong oxygen going at a high flow, and the patient can communicate, patient can take the oral food, oral drugs, everything. So this is going to be quite comfortable. But we need to see whether this is, the efficacy is similar to other modes of oxygen delivery. Now, as I have told you, this is a very quite portable handy machine. This can be wheeled around the ward, and it was initially used in ICUs and HDUs, and later on in the emergency departments and to the medical wards or the respiratory ward. So you can use it for any patients in respiratory distress in most of the places where you manage these patients. Now, setting up of a high flow nasal oxygen to a patient, we usually we look at the clinical indications when hardly any contraindications, and we select the correct nasal font size, half the diameter of a nostril. Then there are two parameters that we consider. One is a flow rate, where you start from around 30 and you can go up to 60. Then you just adjust the flow rate to see whether you get your desired saturation. So once you have achieved that, you just maintain the patient on the flow rate, and you can come down on FiO2. And once the patient is stable, stepping down first starts with the reduction in FiO2. So you come down to around 40% and then come down on your flow rate. And later on, once the flow rate comes to around 15 liters and the FiO2 is 21%, you can change the patient back onto conventional oxygen therapy. There are 4 basic principles involved with high flow oxygen therapy, because I will just take you through these things because they are important in subsequent patient application. So first thing, high flow washes off carbon dioxide in airways. Next thing, because of the high pressures, there is a PEEP effect which recruits alveoli and improve oxygenation. The third physiological effect is the FiO2 that we deliver is at a rate of around 30 liters to 60 liters. So it definitely is higher to the patient's spontaneous breathing effort. So the intended FiO2 is reaching the target alveoli. So you have a predictable FiO2 response. Then next thing is gas is warmed to 37 degrees and humidified, and the mucociliary function is retained, and the patient feels quite comfortable, and your own defense mechanism is still intact. So these are the physiological principles involved with high flow. And you can see it very nicely here. There is a reduction of dead space. There is dynamic positive airway pressure. The airway is well hydrated, and oxygen is well supplemented. And above all, it's quite comfortable to the patient as well. Now, the 4 physiological principles, just revisiting them: reduction of dead space. You just, now this is a radioactive helium tracer in the airway. And on your left, you have a control, and you can see when the flow rate increases from 15 to 40, the tracer more or less disappears, so that there is definite clearance of carbon dioxide in the airways. Now, this is another thing. Now you see the black line is the spontaneously breathing, and the blue line is for patients on high flow. And you see the airway pressure. So there is higher airway pressures which recruits the collapsed alveoli and which facilitate oxygen transfer and then oxygenation, ultimately leading to better outcomes. This, on your left, you see a patient who is on face mask oxygen 10 liters, who is breathing spontaneously at a rate of 30 liters per minute. So definitely now, whatever the oxygen that you give is going to get entrained, and then the concentration FiO tend to fall, and you can't have a predictable FiO2 delivery to the alveoli. In comparison, if you see the other on your right, the high flow rate is 30. At 30, matches the patient's own breathing rate, flow rate, so that the delivered FiO2 reaches the alveoli. So this is how it supplements your oxygen delivery to the alveoli. Humidity also, so you humidify with a humidifier, and you warm it to 37 degrees. So this makes it quite comfortable for the patient as well. It preserves the ciliary function of decontamination. So these are the 4 physiological effects, and we now see what how it improves the clinical parameters. So it reduces the respiratory rate, it reduces carbon dioxide, it increases your tidal volume and also in expiratory lung volumes. So there are quite a few trials that have been done, but these have been the early trials which were very small numbers which were done in ICUs, which showed that there is reduction in respiratory rate. And also the same study, they assessed the rapidity of response, and it's quite surprising that you get the respiratory reduction within 5 to 15 minutes, and the oxygenation also 10 to 15 minutes. The response is quite quick as well. So that is one of the wonders of this therapy. Then it reduces carbon dioxide and it increases tidal volumes and increases end expiratory volume. So these all have been done in very small number of patients, studies done involving small number of patients in ICUs. And also now this is a cohort of bronchiectatic patients. What happens pre-treatment and post-treatment? You see there is definitely reduced mucus clearance. So this all have helped, and then we can assess what the patient comfort. So this is another study which was published in 2010, where they assessed the mouth dryness, overall comfort, and so this all have shown that the comfort and the compliance is better with high flow nasal oxygen. Now, so putting this into clinical practice, so whether this reduces mortality, so whether this reduces escalation of care, whether we can prevent intubation, whether there is comfort and improved patient compliance. So there were few trials that have been done, which I will just, this was later on in 2014 to 16, they all have shown that there is a improving clinical outcome. Now, I will just briefly take you through the 4 categories of patient where the high flow nasal oxygen had been used and proven to be effective in clinical trials. Now, first group was hypoxemic respiratory failure, which was the initial group to be assessed in most of the trials. And this was a landmark trial, which was known as Pleural, which was published in EBM in 2015. They assessed, what they did was they put patients into 3 groups, one on standard oxygen, other one on high flow nasal, and other one on NIV. And their primary outcome was a proportion of patients intubated at day 28, and the secondary outcomes were the all-cause mortality at 90 days. So if you go back to the conclusions, there was no significant difference in intubation rates between the 3 groups, but there is a definitely mortality benefit, significant mortality benefit. So this proves that there is a mortality benefit. This is another test, the study which done high flow nasal cannula adults with acute respiratory failure before and after extubation. So this has shown that it has prevented intubation in comparison to conventional oxygen and NIV. So in hypoxemic respiratory failure, so the mortality has improved, and it has prevented further escalation, that is intubation, in comparison to NIV and conventional oxygen. Traditionally, for hypercapnic respiratory failure, the treatment was non-invasive ventilation. But since this has shown to wash off carbon dioxide, people thought that they can use this, and that was proven in subsequent trials as well. So this is again a study comparing patient with hypercapnic respiratory failure. They were assessing the inspiratory effort, and the inspiratory effort of high flow nasal oxygen at 30 liters was equivalent to NIV. So this is non-inferior to NIV in COPD patients, but obviously the compliance is better. And when you compare the high flow nasal cannula in hypercapnic respiratory, again a systematic review and a meta-analysis which was done in China, published in a Canadian Journal of Anesthesiology. So there was also it's not inferior to NIV, but obviously there is significant advantage over NIV in patients' comfort and compliance. So summary, in hypercapnic respiratory failure, high flow nasal oxygen non-inferior to NIV in delaying escalation of care and improving clinical parameters. So it is equivalent to NIV, but obviously there is an edge because it has a better patient compliance and comfort. So this is where high flow nasal oxygen is very commonly used nowadays, the pre-intubation apneic oxygenation. Now, obviously, this picture shows a patient who has been electively intubated, but you can clearly see even during the process of intubation, the high flow is on. So there is apneic oxygenation. The alveoli are getting a flow rate around 30 flow of around 30 liters. So there, whereas if you're using a face mask or NIV, you need to definitely remove that from the patient during the process of intubation. So is this proven on clinical trials? So this is what we have seen, the Pleural Effusion trial, which obviously concluded that high flow nasal oxygen is superior because it can be retained even during the process of intubation, and it is superior to conventional or face mask oxygen or NIV. The other clinical indication is a post-extubation oxygen delivery. So patients who are extubated in the ICUs are given oxygen either by face mask, or some people are put on NIV, and some people are put on high flow nasal oxygen. So there are studies that have assessed its benefit, and they have shown it to be superior to conventional oxygen or non-invasive ventilation. And again, one of the keys is the patient comfort and compliance. So this has again been tested in several other studies. And this is another study which assess high flow nasal oxygen against face mask oxygen, and that was superior to face mask oxygen in preventing further desaturation and reintubation. Now, my final talk, few minutes, would be on high flow nasal oxygen in severe acute respiratory illnesses, especially COVID-19 pneumonia. Now, this came into limelight a decade ago. That was in 2009, when we were hit with the H1N1. And at that time, high flow nasal oxygen therapy was considered as an innovative and effective modality to early treatment of hypoxemic respiratory failure. So extrapolating this into the current COVID pandemic with severe hypoxemic respiratory failure, where the ICU resources are also stretched, people thought that we could give a try. But there was a concern about aerosol generation, which puts staff at risk. And the other aspect is this needs close monitoring as well to make sure that you do not delay the needed intubation. So, and obviously in COVID, even in COVID patients, this has a role in pre-intubation and post-extubation as well. So I've just visited a couple of trials on this in COVID-19. And this was a trial published done in South Africa, where they assessed the high flow nasal oxygen in a resource constrained setting, and they concluded that it prevented intubation, and then this could also be used in a ward-based setup. And they could wean off most of these patients from oxygen without intubation. This is another study which is quite interesting. They assess two things. One is the success of hypoxemic respiratory failure. Other thing is the risk of aerosolization. So dispersion, and they finally concluded there is not much of a difference between conventional oxygen and high flow nasal oxygen on aerosol generation, but we need further trials. So in conclusion of high flow nasal oxygen COVID, this can be used in hypoxemic respiratory failure it is better tolerated. It has a better outcome. About the aerosol generation, still there is uncertainty, so it's better to use full PPE and can be done in a ward setting, but in either preferably in a negative pressure chamber or isolated room, but it needs close monitoring to make sure that we don't delay intubation if needed. In conclusion, and ladies and gentlemen, high flow nasal oxygen in adults is evolving and growing, and patient tolerance is the key. And it is clearly beneficial in hypoxemic respiratory failure. In hypercapnic failure, it is non-inferior to NIV, but the tolerance, there is better tolerance. Clearly beneficial in pre-intubation and post-extubation, and it has a numerous beneficial effects in respiratory distress associated with COVID-19. Thank you.
Thank you very much, Dr. Krishant Jayasekara. And it's time for questions. Do we have any questions from the audience? Yeah, we have one question. Can high flow nasal oxygen be used in COPD comes with type 2 respiratory failure?
Obviously, yes, not mild to moderate disease. They have shown to be beneficial and equivalent to NIV. Severe disease, there are still ongoing trials, but there is, it does not favor, NIV is better in severe COPD.
I think a very similar question. Can a patient with a very high carbon dioxide levels in the arterial gas with type 2 respiratory failure due to COP exacerbation be given high flow oxygen instead of NIV?
As type 2 is a severe disease, you can try, but you have to be very cautious and you need to monitor very closely. But the evidence is more for mild and moderate disease rather than severe COPD.
Right, thank you. I have a question for you. Now nasal high flow is basically for hypoxemic respiratory failure, yes? But now CPAP therapy that we use for patients with cardiogenic pulmonary edema, could you replace CPAP with nasal high flow in cardiogenic pulmonary edema because it has beneficial effects on the heart as well with the CPAP?
Yeah, actually the benefit is with PEEP effect. We know with a flow rate of 10 liters, we can achieve 1 centimeter of PEEP. So if you give 50 liters, there is 5 centimeter of PEEP that is generated. So theoretical benefit is there. So it all depends on the patient's clinical condition. If there is you can get away with high flow nasal oxygen, especially in cases where the patient can't tolerate the mask. So the problems that we face with CPAP is sometimes people don't tolerate the mask. They become claustrophobic. So these patients, I suppose, yes. To answer your question, I suppose for mild cardiogenic pulmonary edema, you can use, but severe disease where you need a higher PEEPs like of 10 to 15, you might go in for CPAP. But the problem is the tolerance of the mask with the patient.
Yeah, I think the other one that you highlighted on COVID-19, the use of nasal high flow on COVID-19, I think there's some evidence that the aerosol generation could be minimized by a proper application of the nasal cannula, and also if you can put a mask on top of the nasal cannula, it could minimize the aerosol generation and could be a really like an improving and device, especially which may prevent intubation in the COVID-19. Right, okay, thank you very much, Dr. Krishant Jayasekara. Again, I would like to ask Professor Senaka Rajapaksha to hand over the certificate of appreciation on behalf of the Ceylon College of Physicians.